Hey, good afternoon, everybody. We're getting ready to get started. I want to make sure that Dr. Asfour and Dr. Sarpel are ready to join us. There you are, Ramzi. Dost, are you ready to go?
Yeah.
Okay, great to see you. Well, first of all, thank you for everybody for taking time to join our webinar today. We did one about a little over a week ago and had a lot of good questions and follow-up comments. Plus, as everybody knows, we've seen quite a bit of change in what's happening with COVID in the past over a week. So we thought it'd be very valuable to start with another webinar today, and thank you to everybody for joining us. Before we get started, just some housekeeping notes, and probably most importantly, I want to thank all of our physicians, all of our nurses, all of our technologists, and all the healthcare providers that are with us today or might be listening later. They're on the front line. You're all our heroes and heroines, and we are so thankful that you're out there taking care of all the patients today. So thank you for that. HeartCare Imaging, who I'm with, and then Praxis-ID, who Dr. Asfour and Dr. Sarpel are with, both work with rural hospitals throughout the United States. So we have a real love for the rural community and the people that are serving that community. So that's why we want to make sure that we're specifically talking about COVID-19 and rural healthcare today. So we're going to go through this webinar, and it's going to be a three-part webinar. I'll start off, go through just some of the experiences HeartCare has had. We provide imaging services throughout the U.S., Southeast, West, Midwest, Northeast, and we just want to tell you what we're seeing, and it's a little different from section to section, so I think we'll learn a little bit there. Then Dost and Ramzi are going to talk about what's happened since a week ago last Friday, and an update on the COVID-19. And then most importantly, we're going to follow up with a question and answer where we really want you to be involved and ask a lot of questions. We've had a number of them come in already, but we want you to be active and participate so that we can answer these questions for you. So quickly, HeartCare, the slide, we've been around since 1998. We work with large university healthcare systems, which actually brought us into the rural healthcare community, and our focus over the past 5 to 6 years has been on rural health and expanding services needed in those communities. So I thought I'd talk a little bit about what our experience has been in that those areas. So if we could go to the next slide, Chelsea.
Coming up, there we go.
Okay. So we've had different reactions. It's been really interesting. We've seen three different things happen. Some hospitals have closed departments altogether, outpatient surgery, radiology. Some have prioritized case selection, where they're letting the physicians decide the importance of whether the test is necessary or not. And then some haven't changed at all. It's kind of business as usual. We've seen more, almost majority in the middle, where they're prioritizing case selection. And I think that's important to point out. All the focus right now, taking all the oxygen out of the room, is through COVID-19. However, a lot of people are still suffering from heart disease, cancer, other ailments that we need to diagnose and then take care of through different therapeutic means. So we can't take the eye off the ball for the patients that need to have care taken. We've seen policy and procedure implemented. We've been a big part of this. Most of our sites, of course, in fact, I think all of them, are screening the patients by phone, asking all the necessary questions. If you traveled, do you have a temperature, those types of things. And then when they come into the facility, well, before they get into the facility, we're screening them at the door to make sure that they don't have a temperature, and again, asking those questions. Part of the screening by phone also is limiting the interaction with the technologist or the nurse or the physician, because we're explaining the procedures to them on the phone. Things that we typically would do in the lab, we're doing ahead of time so that the interaction with the patient and the caregiver is minimal. And then we've also been diligent about working on schedules. Instead of having patients one after the other, we've tried to space them out over a longer period of time so that the interaction between patients and the caregiver, once again, is limited. One of the things the doctors and I know agree on, because we've talked about it, is telemedicine and the lack of use in America over the past 5 to 6 years. We've all been big promoters of that. but due to lack of reimbursement and lack of understanding, it hasn't really been pushed. Well, if there's a silver lining with what we're going through right now, I think is that telemedicine is really being seen as the advantage we have of seeing patients remotely. And so we're seeing a lot of, in fact, telemedicine is being routinely used throughout the US right now, and it's being reimbursed as a regular office visit. One of the things that HeartCare does is we provide a lot of physician support for the communities that we work in, and typically we do that, by going to the offices. We're doing that either via Zoom or via telecommunications right now. And one of the things that we've pushed, and I know that all of you in your facilities are talking about also, and one of the things that we're doing today, it's important to communicate. We have we have a standard noon call every day with all the managers of HeartCare, where we go through anything that's changed in the past 24 hours. But in between those 24 hours, we're typically on the phone, in the evenings, in the middle of the night, just making sure that everything's going well. I also wanted to mention the legislative update. I'm not going to go through the specifics on this. We have staff that is working on understanding what the $2.1 trillion package that was passed last Friday and signed into law by President Trump. We think we understand a lot of it, and we can answer your questions. The good news is there's a lot of revenue that's going to be available for companies and rural hospitals so that you can survive this this time. And as we are seeing fewer studies being done, fewer outpatient surgeries, those are the procedures and the tests that keep a lot of the hospitals cash flow positive. So we need to be aware of that. I'm not going to go into much on this. If you have questions, email or call us after the call, and we will, if we don't have the answers, we'll get them to you. So with that, I'm going to turn it over to Dr. Asfour to go through his update.
Hi, everybody. This is Ramzi Asfour. I'm the founder of Praxis Infectious Diseases. And we started, actually, before we formed Praxis, we started providing services for rural hospitals, critical access hospitals predominantly, but also some small rural hospitals. Started in 2016, and we've been supporting rural healthcare in antimicrobial stewardship, infection control, infectious disease consultation, trying to help you retain patients in the rural setting, generally keep that revenue, but also take better care, improve the quality of care in general. And we have, between Dr. Sarpel and I, who are the main people in Praxis, as well as our other allied infectious disease physicians, have a breadth of experience in infection control, stewardship, and Dr. Sarpel leads our HIV, hepatitis C, and hepatitis B programs. So we are here to help. Our model has been infectious disease through telehealth, and we think that infectious diseases is a fantastic specialty where telehealth can really be just about as good as in-person care. We, of course, have to rely on the examination of the hospitalist or the doctor seeing the patient in the clinic, but or surgeon, whoever we're associating with. But we help with reviewing labs, writing in charts, giving guidance, helping transfer patients, helping keep patients. It has been a fantastic model, especially in the rural setting, where we can't afford to have a full-time ID doctor on staff. So just a little bit of a brief update where we are today. So there's travel warnings for much of the world. Even countries like Colombia are on full lockdown. You can only go out one time per week to get groceries in the whole country. So these are places where we don't really think of as being highly impacted, but we know that every place is impacted. And the U.S. Would be red if viewed from the rest of the world at this time as well, as we know. We certainly have a lot of cases. This is from the Johns Hopkins website, which is one of the best websites up there. There's many good ones, including University of Washington and others, but this one gives a tally of the cases, also the death tolls. But as you can see, the United States, it has 143,000 cases at the moment. So we're leading unfortunately leading the world in the number of cases at this point. The flattening the curve is an interesting phenomenon. That's certainly what we're trying to do. Everybody's seeing these graphs. But I wanted to show you where China is compared to where the United States is. You can see the light green line. That's the United States. And we've exceeded China, and our curve is not flat. In fact, it's very steep still. So we are still on a very steep curve. Italy as well. Many other countries are on the steep curve. It's only China, South Korea, Taiwan, and perhaps Hong Kong who have really begun to flatten their curves. This is slightly difficult to understand, but I wanted to explain and give you all some background as to why the flattening of the curve is important and really how it's worked. And certainly if you believe the data in China, and some of us don't believe all of the data. In fact, there's an article in the New York Times today about the data in China may not be super reliable, but certainly they seem to have significantly reduced infection. And so this dotted line here represents when they implemented severe, strict restrictions in the city of Wuhan, and this is the daily COVID case count. So the number of cases, this was called, the restrictions are called cordon sanitaire. And once they implemented that cordon sanitaire, you can see that eventually, it took a couple of weeks, but eventually the case count significantly dropped off. And if you see on this slide, this is the growth rate. So a positive growth rate would be above the dotted line, and the negative growth rate would be below the dotted line. And you can see blue is before the cordon sanitaire and green is afterwards. So they were able to significantly reduce their growth rate in terms of infections and flatten their curve. And then this was interesting from a study, a modeling study in Wuhan. And this said, hypothetically, here was basically the peak of infections in the cordon sanitaire. And then when if they released or relaxed restrictions in March, they would push out infections to a peak into the fall, early fall. But if they relax restrictions in April, it would be more towards November. And hopefully by November, December, we'll have some treatments. So this figure on the right is basically how you can push out the peak of this infection. And this is taking into mind a staggered reintroduction of or a staggered discontinuation of physical isolation. I don't like the term social isolation. I think that's harmful in some ways because we're socially isolated. We don't want to socially isolate. We want to stay in connection. We want to keep the human connection going amongst us, but we want to physically distance ourselves. So, but regardless, the fear is that we're pushing a lot of this disease and the peak out there later on. So even if we don't have the expected surge in a lot of places, which is the goal, we might just be prolonging the issue. So we have to be careful about reintroducing closer physical contact with people. And this is, oops, sorry, went too far ahead. So this is just a map of coronavirus on March 19th. As you can see, it was widespread, but not as bad as it is on March 30th. And you can see in lots of places, including some places in Africa. And I believe this is Equatorial Guinea, which is the only Spanish-speaking country in Africa. And Spain has a big problem. So you can see that a lot of cases are there. And interestingly, a lot of the cases in South Africa came from Connecticut, where there was a coronavirus party, quote unquote, where a lot of people were infected and people traveled back all over the world, including to South Africa. So the restrictions that are in place are important. But at this time, we'd like to take your questions, and please raise your hand. Click the button to raise your hand, and Chelsea, our administrator, will recognize you, and you'll be able to ask your question.
Ramsey, maybe I'll get it started. People were a little anxious to ask the first question. One of the things that I think a lot of the critical access hospitals and rural healthcare providers they have a limited number of PPE. So what are your thoughts on how to manage your PPE at these hospitals?
That's a difficult question, and a lot of people are doing different things, but extended use of PPE has become the norm. Certainly issuing every healthcare provider one mask for the day, for example, and then you're supposed to keep that mask for 1 or 2 days at different centers. And Dr. Sarpel, maybe you want to chime in on how some people are thinking about sterilizing or cleaning those PPE.
Yeah, so hello everyone, it's Dr. Sarpel. I'm part of Praxis, as Ramzi introduced me earlier. So a lot of places are looking at using UV light for their masks, and some are looking into using heat. So that's one way you can sort of sterilize N95 masks. And also to conserve PPE, besides just wearing one mask for 1 or 2 shifts, cohorting patients as much as possible so that you only gown up once and then you enter the room and then you can see this 2 patients or 3 patients wearing the same gown, assuming the gown hasn't been soiled or ripped in any way. That's another way facilities are trying to conserve their PPEs as much as possible.
Do we have any questions?
Just a little more on PPE. Certainly, a lot of places can use reusable gowns and washable things that we used to use years ago, and now we've moved to all disposable. So I think we have to resurrect those ideas. Some people are also encouraging, and I think eventually once we have the supply of PPE, that everybody in a healthcare facility, everybody in the hospital will be masking. So right. I think that that's an important step. And some facilities are actually purchasing, people like Gap, and there's a company called Los Angeles Apparel and a few others that are making fabric masks that are washable, that some people are using, for example, for healthcare workers that have been exposed but are not showing symptoms, that they will wear that kind of mask throughout the day unless they go into a COVID or a person of interest or a patient being suspected of having COVID's room, in which case they'll revert to whatever the standard is in their hospital if it's droplet, which is what, in a sense, we're really encouraging, or airborne if they're doing an aerosol generating procedure.
So gentlemen, we have a question from Frank Anstadt. Frank, I'm going to unmute you right now so you can ask your question.
Sure, I mean, just the little question I typed in is your thoughts on equipment maintenance, cleaning, optional safety things that need to be done, and in particular, what should people do differently outside of their current operations in maintaining their equipment?
So for equipment, it's a great question, Frank. First of all, you don't need a different kind of cleansing product than you're already using. So keep that in mind. Bleach is not better than quat, or it's not better than peroxide. So it's not like C. difficile where you have to really think about which product you're using. You need to use the product and follow the manufacturer's recommendations on dwell time and wet time. But the viral particles are relatively easily disrupted by alcohol and even soap and water. So depending on what surface you're cleaning, I think it's about increasing the frequency of cleaning at this point. So if you're talking about imaging equipment, after a patient, a wipe down, especially if it's a suspected patient, would be in order. But if you're, if it's within a patient room, for example, patients had remote control, you might not do a focused cleaning on that except routine standards, but then obviously with a terminal clean, when the patient leaves the room, that would need to be all the high touch surfaces, and you would need to handle it as you would a terminal clean, except that you wouldn't necessarily need to use bleach like you might for C. difficile.
Great. We have another question from James Avery. James, I am unmuting you.
Yeah, hi, Dr. Sarpel. This is James Avery with HeartCare. Just had a quick question about treatment protocols that you have seen across the board, maybe at your hospital or at others. Primarily for patients with pneumonia after COVID-19.
It's a good question, especially since FDA just had an approval, emergency approval for hydroxychloroquine, which is Plaquenil, and chloroquine for treatment of COVID patients. Most studies use a 5-day treatment protocol with hydroxychloroquine. It seems to be has less side effects than chloroquine, and also seems to have more activity against SARS-CoV, which is a virus that causes COVID. So most centers are focusing on hydroxychloroquine. The data it's still only small studies. None of them are randomized. They're not like placebo controlled, anything like that. Just observational studies. There are a lot of studies ongoing here as well as in China looking into their use. Most places are mainly just using it for patients who are admitted to the hospital and who are at risk for decompensation or have already decompensated and are in the ICU. Some centers were also adding azithromycin or a Z-Pak to the treatment protocol, but it was based on one very small study, and it actually probably isn't as good as that study suggested. So most centers are now shying away from using azithromycin with hydroxychloroquine. And then there are other drugs out there. So there's Remdesivir, which it's a Gilead drug. That is undergoing a lot of trials, and before Gilead was giving out in compassionate use, but now you need to request to be on a trial with them, so you can't really get it via compassionate use anymore. But that drug seems to have some activity, and then there are other IL-6 inhibitors. So tocilizumab is one that's being looked at. It's like one dose, and a couple other drugs in that class. They're used mainly for certain cancer diagnoses. So your facility may have them on hand for chemo reasons. So if you do, that's one treatment you can look into. So far, really, those are the only treatments going on, but there are a lot of trials, and there's actually trials looking into prophylaxis, pre-exposure prophylaxis and post-exposure prophylaxis with hydroxychloroquine, although, again, there's no data for prophylaxis use yet. So those are some of the drugs that are out there that are being used right now.
Okay, we have a question from Stacy Green. Stacy, you are unmuted. Hold on. Nope, it says you're self-muted. There you go.
In our previous presentation, we talked about excess bed capacity in the U.S. healthcare system being with critical access hospitals and rural health hospitals. What do they need to do to help improve the care of the patients that they are seeing kind of roll over into their systems?
Thanks, Stacey. That's a great question. And I think that we do have to keep in mind where the bed capacity is in the U.S. healthcare system. It's not in New York City. It's not in big metropolitan centers. It's in our rural hospitals. Some of whom have maybe an average census of a few patients, and they have capacity for 25. So I guess the problem is staffing. But if you can get retired physicians, retired nurses in the community to help, and if staffing ratios can be flexed, so a lot of places are actually submitting flex requests for staffing that and you can use as task shift, sort of from what a CNA can maybe do some of the things that a nurse would normally do, and so on. But we do have a lot of capacity, and some countries have are transferring people on across the country. France, for example, is transferring people on their high-speed trains from one region to another, and they've dedicated a couple of trains to do that. So we could certainly transfer patients from one facility to another, and many states, Kansas, Texas, and many others have in most counties, even if the population isn't that high, they might have a critical access hospital, and so those hospitals might have the capacity to take some of the less ill, certainly, patients to decrease the burden. But another way to think about it is some of the hospitals can take some of the more routine non-COVID patients as well. So like what they're thinking of doing on the two Navy hospital ships on each coast, that they're not planning on taking COVID patients. Obviously, they're going to end up with some COVID patients that have not been properly diagnosed. I'm wondering, I've got a good friend who's a Navy doc on the Mercy that's now in LA, and we'll see how that goes. But we could take some of the patients that if you have orthopedic services or surgery service or just medicine services for you have a patient with diverticulitis, you might take that patient, or a gallbladder problem, or a bacterial pneumonia with a negative COVID test, or congestive heart failure. You could transfer those patients from an ER at a bigger hospital to a rural hospital, and so we need to be creative and communicative. Exactly what Bob said earlier is that communicate with our local referring providers, not how can you help us, but how can we help you? Let's take some of your patients that we can manage them in our rural facility, and so we'll do the reverse kind of a transfer than we're used to doing from the critical access hospitals. And Medicare has lifted a lot of regulations around that, including bed capacity. So for those facilities who have the ability they might have a long-term unit or some SNF beds in their building, they can actually convert those into acute care beds, and so they can bump the census beyond 25 if needed as well. So there's a lot of creativity, flexibility. I know we're losing income because of the cancellation of certain procedures, which we need to really think about, and we're not going to be able to sustain that. But in the interim, can we take some of these other patients to increase revenue, but also to provide, obviously providing care is the most important thing, but we want to stay afloat as well. And so I think let's be creative and communicative.
We have another question from James Avery. James, you are unmuted.
Yeah, my question is regarding PPE and the use of PPE during a nuclear stress test. Do you find, we're in close proximity with the patients sometimes when we're putting them on the table or getting them prepared for the stress test. What would you suggest we do in that event with PPE?
Dr. Sarpel, do you want to take that?
Sure. So number one, obviously this isn't a patient that there's suspicion for COVID. So they should be wearing a mask during transport in the hospital as well as during the test. So that's probably the most important thing you can do. In regards to the other PPE, I would say the transporters and whoever is doing the test should also be wearing a mask as well. I don't think, I think a surgical mask is fine. I don't think they would need an N95 in that setting. And in terms of whether or not a gown is needed, probably not, assuming, this is, if you're doing a nuclear stress test, this patient's probably not that sick. Their viral shedding's probably not that high. They're not, coughing up everywhere. You're not doing an aerosol producing procedure. So you could probably just get away without the gowns. I don't know. I mean, that's what we're doing at some facilities that I'm affiliated with. I don't know, Dr. Asfour, if you wanted to add on to that.
Yes, I mean, no, I think you said it fairly clearly.
And that's one of the things that we've really tried to do by communicating with the patient prior to them even arriving at the facility to understand what's going to take place so that there's less time, face to face with that patient. They walk in, they know what to expect, and then you go on with the test. Let me ask you a question that it's kind of a controversial question. And Dr. Asfour and I talked about this last week. Just want to get your thoughts on it. We're HeartCare, we're based down here in Florida. Dr. Sarpel, you're up in New England, and Dr. Asfour, you're out in California. So we're in three pretty delicate spots right now. But one of the things we're hearing in Florida is the increase in number of planes and cars coming into our state from New York and New Jersey. And just what are your thoughts on what's happening with the migration of patients, or not really patients, but people, and how that's going to affect the spread of the disease ultimately?
Yeah, that is a controversial question. I know that Rhode Island is really trying to track down anyone from New York. So if you have a New York license plate, state troopers are stopping you and asking why, what you're doing, and they're requiring, because they can't force it, but they're trying to get people to quarantine for 14 days after travel from New York. And Rhode Island's really enforcing that. I mean, the cat's out of the bag, so to speak. It's already out there in the States. If this was 2, 3, 4 weeks ago, maybe, really quarantining those people traveling from hotspots might have made a difference. But I mean, it's already out there. It's already in Florida. It's already in Nevada and all these other states. So, limiting or placing a travel ban on one part of the country at this point, I don't think really would add much to flattening the curve, more than what states are already doing in terms of their shelter-in-place orders and stuff. I don't know what your thoughts are, Dr. Asfour.
No, I agree. I don't know how much. Certainly, lots of cases have been spread by travel, as I mentioned, even to South Africa or to small countries like Equatorial Guinea from Spain. So that's it's a known phenomenon, and certainly avoiding unnecessary travel is a smart thing to do. So that I think I completely agree with that. But you don't want to completely shut it off. What if what if somebody lives in New York, and their elderly mother who's alone in Florida, fractures her hip and or is at home and not sick enough to go to the hospital, but doesn't have COVID, has something else. There's a lot of things that will end up being exceptions, and if people can really respect the physical distancing, then I think that's the most important thing. The problem is not everybody nationwide is respecting that. So we saw pictures in spring break in Florida we saw pictures in last weekend, and it was a nice weekend in where I live near San Francisco, and the people were on the beach and in huge numbers, and they finally reacted by closing all the parking lots, and you can only go to the beach if you can walk there. And I heard in San Diego County, you're not allowed to sit on the beach, but you're allowed to walk. So if they find you sitting, they will push you along. So there's a lot of, we really do need to think about this. I'm faced with these questions. My daughter wants to go on a bike ride with her friends. She wants to maintain 6 feet. She said she maintained 6 feet distance. I still said no. I felt really bad doing it, but it's, it's a tricky situation that we're in.
We have a couple more questions coming in. Next up, Henry Desplains. You are unmuted.
Yeah, good afternoon. We hear about all these drugs that are being looked at, and we've got an unprecedented marshaling of forces with the drug companies, scientists, you name it. We're reducing times for testing and so forth. What's a realistic time frame to get an effective vaccine in your view? 6 months, a year, 18 months, something else?
So for vaccine, they just started a couple weeks ago. They did the first human injection of the very first vaccine, but that's just to see if it's safe, and they have to figure out the dosing and then do other trials. So even at warp speed, it's still not going to be for probably 8 to 12 months. That's what everyone at the WHO, CDC, what Anthony Fauci are all saying. So best case scenario is 12 months, maybe a little shorter. And even then, that's unheard of in the modern medicine to get a vaccine out that quickly. So that's probably what we're looking at for vaccine. Treatment-wise, that we could probably get out sooner. Like I said, there are some studies with hydroxychloroquine that seems to have some effect. Now there's a lot of studies looking at what's called the cytokine storm. That's where IL-6 inhibitors may come into play. I know China is now looking in immunoglobulins because they have all these people that have had COVID and now recovered. So looking at that. So I would think that treatments will become more available prior to any vaccine.
Chelsea, do you have any more questions?
Sorry, I was on mute. We do have a couple more questions. One from Dakisha Bryant. I'm going to unmute you. If you wouldn't mind just letting us know where you're calling in from, that would be wonderful.
Hey, good evening. Can you hear me?
We can.
Okay. We're calling in from St. Francisville, Louisiana. And we were just wondering if you've heard of any contraindications of giving iodinated contrast to COVID or suspected COVID patients.
I have not. I don't know if you have, Dr. Asfour.
No, I have not. I don't think that's a concern at this point. We're not really worried about renal function. The disease does not seem to, at least initially, affect the kidneys. So we have not heard of concerns.
Okay, thank you.
You're welcome. I would also go further to say that I would recommend using contrast for CTs when you're looking for infection. So I'm not a radiologist, but I generally order my CTs with contrast in these cases.
To add on to the CTs, oh, sorry, go ahead.
Nope, go ahead.
I was going to say, using CT chest, there are some typical findings you see with viral pneumonitis, which, COVID is. So, these peripheral ground glass opacities, and they can be helpful in diagnosis. Hopefully you have testing, you'll be able to test the patient. What we've instituted at some facilities is, we try to avoid CT scans or any radiographic imaging on these patients, but if you have to, for whatever reason, then, again, the most important thing is putting a mask on the patient when you're transferring them to the radiology unit, and then wiping down the table in radiology.
We have a Cheryl Hood that typed in her question. Her question is the U.S. getting in on Avigan trials?
Sorry, which trials?
Avigan?
That's the Japanese influenza drug, I believe. And
Yeah.
And I don't know that we are getting in. I don't know of any trials in the U.S. yet. I know in Japan they're working on that, but
Yeah, I don't know of any trials in the U.S. on that. There are several antivirals that are looking at, but that's not one that I know of that they're looking at here in the U.S.
Okay, we have a question from Tommy Aiken. Tommy, I'm going to unmute you and let us know where you're calling in from.
Hello, I'm calling in from Gainesville, Florida, and I really have a supply chain question related to PPE. I was wondering if you guys may not, know the answer to this question, but just curious if y'all have any inside information on the manufacture and distribution of any and all PPE type equipment for our first line responders, or even our technologists and radiology departments.
So right now, to get extra PPE from the national stockpiles, you have to go through the county, your local county. In most states, that's how it's working right now. So in I know in California, Arizona, Nevada, a few others for sure, but it's likely the same. You make a request to the county. The county has contacts with wherever the national stockpile is for your state, and they can release. They might be able to release extra PPE. They prioritize it, and then they have access to extra PPE. So it has to be done from the health facility to the county, and I don't know that you can do it from the imaging department only directly, and a lot of people are going to other companies. There are some companies in China that are exporting. I do have some contacts. I can't vouch for the reliability of those. So if you're interested, feel free to reach out to me afterwards. But there are again some American companies like the Gap is starting to make PPE. Lots of companies locally are starting to make PPE. There's a furniture company in Seattle that's making PPE as well. So this is great news. We're going to have a lot more in a couple of weeks. Some of it will be reusable, washable, and some of it will be disposable. But I think that's great. We're hopefully going to have a lot more online soon.
And then the other thing I would just add to that, a lot of construction companies and HVAC companies have been donating their industrial, they're not N95s, they're N99s and other masks that can be used per some of the CDC guidelines if you don't have an N95 available. So I know that a lot of facilities have reached out to local construction companies, and that's something that you can try doing too, to see if they have any masks that they can donate.
We have Jacqueline Hall wrote in 2 questions. What testing capacity do you think facilities should have, and is 14 days the magic number because that's how long the virus stays in the body?
So what testing facilities should have is a difficult question. I think it depends on the machines, the testing equipment you already have. So if you have the Cepheid machine already, the Gene Expert, and you're doing some tests on that, then stick with that. Cepheid has already started shipping coronavirus testing cartridges out for their Gene Expert If you don't have that, you might have the Abbott machine that you're already using for rapid streps, for example, or they do influenza as well. So you might, so Abbott announced that they have FDA approval for those rapid tests, and that's a 15-minute test. So that would be a fantastic test to have. There's a lot of other companies. I would be careful if you're going to beyond one of the big names in this space and using other tests. There's a lot of startups starting tests. We don't know how well they're validated. There's some that have antibody tests, which is really exciting. We need to get antibody tests. We need to figure out which of us have already had the illness and therefore perhaps are at less risk for contracting it, and we can be cohorted to taking care of the COVID positive patients, because the risk to our health is very close to, is very, very low from, we don't think that repeat infection can happen. The 14 days is the magic number. Well, that's the average incubation period is somewhere between 4 and 6 days, perhaps. So 14 days is the outside of the incubation period, but it's 14 days after the contact. But now we're having widespread community activity. So 14 days, while still considered, you should isolate for 14 days. If you're not sick at the end of that time, you're likely not infectious. But if you get sick at day 10, then you're infectious for beyond 14 days conceivably. So it depends on when the exposure occurred. But most people are probably not infectious beyond after an exposure beyond 7 to 14 days. But we're saying 14 days for safety for most people.
So just to add to the last part, the 14 days is because some studies have shown it, but honestly, as Dr. Asfour said, if the vast majority of people become symptomatic by day 10, I mean, it's very few afterwards, but it can happen, but it's rare. In regards to the testing, another big company is BioFire. So they do multiplex PCR systems. So if you have access to BioFire, they're working on, they don't have it yet, but I know they're working on a SARS-CoV PCR as well to add on to their panel. So it's another company to look into.
We have 2 questions from Marilyn Magar. What can seniors do, if anything, to boost their immunity or strengthen their system? We'll start with that one.
Okay, so
you want to take that? No, you.
Okay, I mean, I get asked this a lot. What can people do? And I think the number one thing is sleep. Get adequate sleep. That's certainly the for your own immunity. That's number one. If you're talking about strengthening your immunity, it's sleep. People have talked about taking higher doses of vitamin D, but that can actually upregulate the ACE2 receptor, and the ACE2 receptor is what binds COVID. So you don't necessarily want to take super high doses of vitamin A or vitamin D. There's actually some trials going on in some New York hospital chain, the one that owns Lenox Hill Hospital. I forgot their name. But they're trialing vitamin C IV. So they're giving 1,500 milligrams of vitamin C intravenously every 8 hours roughly. And they have a trial protocol. There is a trial in China using vitamin C intravenously as well. But certainly taking a little bit of vitamin C is not likely to hurt as a supplement. If you can find some, they're all sold out. And then again, avoiding exposures if you're older, sheltering in place if you're in one of the higher risk groups. If you're over, a senior over 75 certainly, or 70. Just some good news. There was the World War II veteran. He is an Italian guy. He was born in 1918. He survived the Spanish flu. He survived World War II, and he was just yesterday released from a hospital in northern Italy at the age of almost 102, with having recovered from COVID. So, you know, some older people are recovering from COVID. So that was a little bit of light in this dark time.
And I would just add to Dr. Asfour's comments, exercise, obviously, not anything crazy, but just a little bit of exercise definitely can help as well. And we know that from a lot of studies looking at the elderly and their response to vaccines and other things. For instance, doing Tai Chi is known to boost your immune system. So that definitely can help as well.
Absolutely.
Well, it seems like that is all the questions that we have. If anybody else has any questions, feel free to write them in the question box, and I'd be happy to ask the doctors or raise your hand.
And just I'll let the doctors finish, but to wrap up from HeartCare standpoint, we've recorded this presentation and we will be sending it out. If you're on, feel free to send it out to others you might think it could benefit. And we'll kind of see what kind of reception we get, and potentially do another webinar in a week as things move on. I just want to thank Dr. Asfour and Dr. Sarpel. You know, amazing. Thank you so much for your time, you know, giving it to all of us, your expertise, so that we can better educate ourselves on what we can do to fight this pandemic.
Thanks, Bob. And thanks everybody. It was great. If you want to reach out to us, our information was in the invitation. Feel free to do so, and we'd be happy to help and look at your particular situation.
Really quick before everybody goes, Henry Desplaines would like to ask another question. One moment. Henry, you're unmuted.
I'm sorry, I hit that button by mistake. Thank you.
All righty. We are getting a lot of thank you all for your time and your expertise. We appreciate everybody being on.
Thank you, everybody.
Thanks, everybody. Yeah. Thanks. Thank you, guys.
Okay, bye-bye.